Today's topic, we are going to discuss the top. Хорошо. Uh-huh. Hello, dear students. Today we are going to discuss the examination and investigations of the cardiovascular system in normal adults. Before beginning the lecture, I again remind you the sequence of examination. First inspection, then palpation, after percussion, and at last auscultation. We should begin the examination at the end of the bed with an inspection of the patient's general condition and their surroundings. In the examination, it's important to note signs such as dyspnoea, pallor, or cyanosis. Note any medical equipment attached to the patient or in the bedside. You should begin the examination from the hands. First of all, move to the left-hand side of the bed, the patient's right side, and examine their hands. Begin by inspecting the fingernails for splinter hemorrhages, then clubbing. Splinter hemorrhages are reddish-brown linear hemorrhages lying parallel to the long axis of the nail, like this. They are a sign of previous trauma, classically gardening or mechanical work, or pathologically of infective endocarditis. Here also you can see on the picture the splinter of hemorrhages. This is the late appearing symptom in endocarditis. This represents damage to capillaries, may also appear due to nail trauma. Then examine for clubbing. Clubbing is an enlargement of the soft tissue of the distal phalanges resulting in an exaggerated nail curvature, nail fold bogginess, and in angle of greater than 180 between the nail and nail fold. Examine each of the fingers of each hand for these signs. Clubbing is an important sign, but evidence suggests that it has poor precision. Schamroth signs may be a more reliable way to diagnose clubbing. The Schamroth's window tests. Normally, the fingers should be like this. Try to elicit Schamroth's sign by asking the patient to curl the fingers of both hands towards the palms and then bring their hands together so the nails and distal interphalangeal joints of the two middle fingers touch. If clubbing is absent, there should be a diamond-shaped gap between the two nails. The loss of this gap is Schamroth sign and is an indicator of clubbing. Here you see there is no any sign. Note the loss of the diamond-shaped window that appears between the two fingers when cuticle areas are placed next to each other. This is the normal. You see the narrow gap, it's rhomb shaped or diamond shaped, and here you don't see any gap, and these are clubbing. Examine the dorsum of the hands. Inspect along the extensor tendons for cholesterol deposits called xanthomata. These are irregularly shaped yellowish nodules on the skin. Note the temperature of the hands and the color of the skin. Assess the patient's peripheral perfusion by squeezing the fingertip firmly for 5 seconds, then letting go and recording the time taken for normal color to return, like this. This is the capillary refill time and should be less than 3 seconds. A delay indicates poor perfusion of the extremities, which may be caused by hypovolemia, hypothermia, peripheral vascular disease, or just cool peripheries with associated vasoconstriction. Next examination is pulse. A pulse is felt every time the heart beats. The pulse is the beat of the heart felt at an artery as a wave of blood passes through the artery. Pulse sites are temporal, carotid, brachial, radial, femoral, popliteal, posterior tibial, and dorsalis pedis or pedal. These pulses are on each side of the body. Radial pulse is used most often. Carotid pulse is taken during CPR and other emergencies. The apical pulse is felt over the heart. This pulse taken with stethoscope. Here, this pulse we should examine: radial pulse, brachial, temporal, carotid pulse, facial, femoral, popliteal, posterior tibial, and dorsalis pedis. The radial pulse. The radial pulse at the wrist is generally examined using the palm of the three fingers: index, middle, and ring finger. The patient's forearm is held in semi-pronated position and the wrist is slightly flexed. Assess the rate, the rhythm, and the character of the pulse. The radial pulse establishes the rate in beats per minute by counting the number of beats over a 15-second period and multiplying by 4. The normal resting heart rate should be between 60 and 90 beats per minute. Analyze the rhythm of the pulse and decide if it's regular, irregularly irregular, or regularly irregular. In normal adults, pulses may be described as normal and symmetrical. A regular pulse is at a constant frequency with a constant interval between the beats. If it's not of a constant frequency, it's irregular. Irregular pulses are conventionally divided into regular irregular and irregularly irregular. A regularly irregular pulse has a repeating pattern. For example, 2 beats close together, then a gap, and then another 2 beats close together. If there is no repeating pattern and the beats seem to arise randomly, then the pulse is said to be irregularly irregular. The peripheral vascular system. Patient is in sitting position. Throughout your assessment, compare one side with the other. Inspect both arms from the fingertips to the shoulders. Note the color and texture of the skin and nail beds, the venous pattern, and edema. Using the backs of your fingers, note the temperature of the arms, comparing one side with other. Inspect both legs from the groin and buttocks to the feet. Note the color and texture of the skin and nail beds. Hair distribution on the lower legs, feet, and toes. Pigmentation and ulcers, the venous pattern and evidence of venous enlargement. Edema. The dorsalis pedis pulse. Feel the dorsum of the foot just lateral to the extensor tendon of the great toe. In normal adults, pulses is normal and symmetrical. The dorsalis pedis pulse may be congenitally absent. Its absence, therefore, is not diagnostic. Sometimes another artery in a more lateral position supplies the dorsum of the foot. It's the posterior tibial pulse. Curve your fingers behind and slightly below the medial malleolus of the ankle. Here. In normal adults, pulses is normal and symmetrical. This pulse may be hard to feel in a fat ankle. Then ask the patient to stand and inspect the saphenous system for varicosities. Assess the temperature of any varicosities. Place the back of your hand along varicosities to assess the temperature. Increased temperature can indicate inflammation, for example, phlebitis. Assess for putting edema in the limb. Then assess tenderness. If there is saphenovarix, ask the patient to cough to emphasize it. If you feel an impulse over the CVG, this indicates saphenovarix. Dilatation of the saphenous vein at the saphenofemoral junction. Heart rate, heart rhythm, and blood pressure. Patient should be in sitting position. The radial pulse is conveniently used to assess heart rate and rhythm. With the pads of your index and middle fingers, compress the radial artery until a maximum pulsation is detected. Count the rate and note any variation in rhythm or amplitude. Normal heart rate is from 60 to 90 beats per minute. It means that the heart rate should equal to the pulse rate. Heart rhythm normally is regular. Blood pressure may be measured satisfactorily with a sphygmomanometer or either the aneroid or the mercury type. Upper limits of normal blood pressure in adults have traditionally been set at 140 per 90, and lower limits of normal blood pressure estimated at 100 per 60 millimeters. Plus pulse pressure equal to systolic, the difference of systolic pressure and diastolic pressure, and normally equals to 35 to 55 millimeters. Blood pressure should be taken in both arms at least once. Normally, there may be a difference in pressure of 5 millimeters, sometimes up to 10 millimeters. And according to this table, normal blood pressure should be systolic under 120, diastolic under 80, and prehypertension is from 120 to 139 and 80 to 90 N, and so on. After that, we should examine the carotid arteries. Patient should be in lying position with head of bed raised to 30 degrees. Inspect the neck for pulsations. Carotid pulsation may be visible just medial to the sternomastoid muscles. In normal adults, there is a mild carotid pulsation symmetrically from both sides. Feel the carotid pulse comparing one side with other. Note any palpable thrills. After that, using the right side, carefully assess the amplitude and counter of the pulse wave. Amplitude of the pulse can be correlated with the pulse pressure. In healthy adults, the amplitude is normal and there are not any variations in amplitude from beat to beat and with respiration. The counter of the pulse wave, for example, the speed of its upstroke, the duration of its summit, and the speed of its downstroke. The normal upstroke is smooth and rapid. The summit is smooth, rounded, and the downstroke is less abrupt than the upstroke. If the patient is middle-aged or elderly, listen to the carotid arteries with the diaphragm of your stethoscope. Ask the patient to hold his breath so that breath sounds do not obscure an artery sounds. In normal adults, two artery sounds may be listened. First originates in the carotid artery itself. Second, irradiates from the aortic valve. Jugular veins. Position the patient so that he is relaxed and comfortable with his head slightly elevated on a pillow and his sternomastoid muscles relaxed. Usually, the head of the bed needs slight elevation, 15 degrees to 30 degrees from the horizontal. Use tangential or oblique lighting and examine both sides of the neck. Identify the external jugular vein on each side. Then find the pulsation of the internal jugular vein. Here should be. Since the vein lies deep to muscle, you won't see the vein itself. Look for them in the suprasternal notch between the attachment of the sternomastoid on the sternum and clavicle, or just posterior to the sternomastoid. Identify the highest point at which pulsation of the internal jugular vein can be seen. And this is a centimeter ruler measure the vertical distance between the point and the sternal angle. The normal venous pressure is less than 4 centimeters above the sternal angle. Then, examination of the heart. Patient is still in lying position with head of bed raised to 30 degrees. Inspection. Try to detect the possible heave or precordium. Tangential lighting helps you detect cardiovascular pulsation. Observing the chest surface tangentially is also useful, allowing you to see the pulsation on edge. Observe the 5 topographic areas. The apical of left ventricular area, it's the 5th intercostal space at or just medial to the mid-clavicular line. Inspect the chest wall in and around the area including the 4th, 5th, and 6th interspaces. Try to identify the apical impulse. This is the left ventricular area. So we should inspect 4th, 5th, and 6th intercostal area. The right ventricular area, lower half of the sternum, and the parasternal area, especially on the left. Then epigastric area, the pulmonic area, and the aortic area. So right ventricular area, aortic area, pulmonic area, and epigastric area. The apical area, normally the apical impulse is just medial to the midclavicular line in either the fifth or fourth interspace. The epigastric area is the pulsation of the abdominal aorta, may often be seen here in a normal person. You can feel the apical impulse in at least half of adults. This impulse is a brief systolic beat. The apical impulse, normally located in or about the fifth costal interspace inside the left midclavicular line when the patient is supine. The extent of impulse is about 2.5 centimeters. Parameters of apical impulse. First, location. Just medial to the midclavicular line, about 1.5 centimeter in either the fifth intercostal space. Here. Second parameter is diameter. Diameter is about 2 centimeter or less. Usually occupies only one interspace. This diameter. Next parameter is amplitude and force. Small amplitude light when cardiac output is increased, as in anxiety or pregnancy, the apical impulse may have increased amplitude. The last parameter of apical impulse is duration. It begins about at the time of the first heart sound and is sustained during the first third to half of the systole. In cases of right ventricular hypertrophy, pathological impulse may appear in the fourth intercostal space to the left of the sternum and or epigastric pulsation. After palpation, we should percuss the heart. Palpation has replaced percussion when estimating cardiac size. If you cannot palpate the apical impulse, percussion may be your only option, but has limited correlation with the cardiac bodies. Starting well to the left on the chest, percuss from resonance towards cardiac dullness in the third, fourth, fifth, and possibly sixth interspace. Assessment of the right, left, and upper borders of the cardiac dullness. The right border of the heart is formed by the right atrium by the 0.05 to 1 centimeter lateral to the right sternal line in fourth interspace. The left border of the heart is formed by the left ventricle 1 to 1.5 centimeters medial to the midclavicular line in the fifth interspace, and the left atrial appendage makes up the upper border, third rib. Rules of auscultation. After percussion, we make an auscultation of the heart. The heart is usually auscultated by a stethoscope or a phonendoscope, but direct or immediate auscultation is also used. If you see it in this picture, Before the discovering by Lionx the stethoscope, all doctors listen to the heart by direct or immediate auscultation. And nowadays, we auscultate by stethoscope or phonendoscope or stethophonendoscope. If the condition of the patient permitting, the heart sounds should be heard in various postures of the patient: erect, recumbent, after exercise, for example, after repeated squatting. Sounds associated with the mitral valve's pathology are well heard when the patient lies on his left side, since the heart apex is at its nearest position to the chest wall. Aortic valve defects are best heard when the patient is in the upright posture or when he lies on his right side. The heart sounds are better heard in the patient if the patient is asked to inhale deeply and then exhale deeply and keep breath for short periods of time so that the respiratory sounds should not interfere with auscultation of the heart. The valve sounds should be heard in the order of decreasing frequency of their affection. Examination sequence. Explain to the patient that you wish to examine the chest and ask the patient to remove his clothing above the waist. With the patient lying at approximately 45 degrees to the horizontal, listen over the precordium at the base of the heart, apex, and upper left and right sternal edges with both bell and diaphragm. Also listen over the carotid arteries and the axilla. At each side, identify the first and second heart sounds and assess their character and intensity. Note any splitting of the second heart sound. Concentrate in turn on systole, the interval between S1 and S2, and diastole, the interval between the S2 and S1. Listen for added sounds and then for murmurs. Roll the patient onto the left side. Listen at the apex using light pressure with the bell to detect the mid-diastolic and presystolic murmur of mitral stenosis. Here it's shown the sequence of auscultation. In our country, we should begin the auscultation from the mitral valve. The mitral valve is at the coincides with the heart apex, here or here. Second is the aortic valve. It's in the second intercostal space to the right of the sternum. Next is the pulmonary valve in the second intercostal space to the left of the sternum. The same intercostal spaces, but other side. After that, we should auscultate tricuspid valve. It's on the base of the xiphoid process or below the xiphoid process. And the last is it's the additional point named after the discovered this point, Botkin-Erb's point. Here. It's located on the third intercostal space on the left side of the sternum. Here you can see the mnemonics, how to memorize the heart valves. You can memorize all People Enjoy Time magazine. It means aortic, pulmonic, Erb's point, tricuspid, and mitral. And also next mnemonics is all physicians take money: mitral, aortic, pulmonic, and tricuspid. Auscultation involves listening for heart sounds with the stethoscope, similar to the procedure used in assessing breath sounds. The sounds produced by a working heart are called heart sounds. Two sounds can be well heard in a healthy subject. The first sound, which is produced during systole, and the second sound, which occurs during diastole. Heart valves and heart sounds. Closure of the atrioventricular valves create the first heart sounds. It's heard like lub. Closure of the semilunar valves create the second heart sound. It's heard like dub. Placement of a stethoscope varies depending on which heart sounds and valves are of interest. First heart sound is S1. The characteristic is loud sounds produced by atrioventricular valves. S2 characterized by also loud sounds and produced by semilunar valves. S3 and S4 sounds are soft sounds and blood flow into ventricles and atrial contraction. Causes of S3: physiological, children and young adults less than 40 years, it takes nearly 25%, not heard in normal infants and adults less than 40 years. Pathological, ventricular failure, hyperkinetic state, systemic atriovascular fistula. Causes of S4: physiological, less than 60 years, recordable, not audible. Pathological, all causes of concentric LV and RV hypertrophy, coronary artery disease, acute regurgitation lesions, and easily audible S4 at any age is generally abnormal. Listen first with the diaphragm in all areas, then with the bell. The diaphragm is better for picking up relatively high-pitched sounds such as S1, S2, etc. The bell is more sensitive to low-pitched sounds such as S3, S4. With your stethoscope, identify the first and second heart sounds, S1 and S2, starting at the apical area. At normal and slow rates, S1 is the first of the paired heart sounds, following the longer diastolic period and preceding the shorter systole. At the apical area, S1 is normally louder than S2. S1 just precedes the carotid impulse. Identify the heart rate. Count the rate per minute. If the rhythm is perfectly regular and seems to be normal in rate, you may count for 15 seconds and multiply by 4. Normal heart rate is from 60 to 90 per minute. Identify the rhythm. In normal persons, the rhythm is regular. And the characteristic of S1. S1 is louder than S2 at the apex and it's softer than S2 at the base. At the base, S2 is normally louder than S1. Splitting. S1 may normally be split in the right ventricle area where the tricuspid component, usually too faint to be heard, becomes audible. Physiological splitting of the second heart sound can usually be detected in the pulmonic area. The pulmonic component of S2 is usually too faint to be heard at the apex of aortic area where S2 is single and derived from aortic valve closure alone. Normal splitting is accentuated by inspiration and usually disappears on expiration. This is all. My lecture is over. Thank you for attention.